Hello, my name is Alicia Pilarski, and I am an Associate Professor of Emergency Medicine at the Medical College of Wisconsin. I will be presenting on behalf of my team today regarding our project, the use of human-centered design to improve resident well-being. Burnout in medicine is occurring at alarming rates, especially in residents who report it on average of 45 and up to 64% in some specialties. While a focus on improving systems and the clinical learning environment are a priority to improve well-being for residents, education and promotion of well-being and resilience have both been recognized as important and beneficial in the training of our future physicians. The Accreditation Council for Graduate Medical Education and other governing bodies have supported implementation of various well-being initiatives in training programs to help foster the well-being and resilience of residents. Even when well-intended initiatives are incorporated, however, they often lack necessary funding, leadership, and program support, which can translate into inefficient or poor quality initiatives that do not improve resident well-being. Human-centered design is an approach to problem solving that has been used in medical education, design, and management frameworks to explore complex problems. The goal is to develop solutions to problems by involving the human perspective in all steps of the problem-solving process, specifically observing the problem within its context, brainstorming, conceptualizing, developing, and implementing the solution. This approach enhances effectiveness and efficiency, improves human well-being, user satisfaction, accessibility, and sustainability. Our project aims to assess residents' desired well-being initiatives using a human-centered design process and to evaluate the current well-being initiatives across the graduate medical education programs at our institution. This IRB-approved study began with scheduling human-centered design sprints, 1-hour facilitator-led interactive sessions with approximately 25 to 30% of resident volunteers from 10 residency programs of the Medical College of Wisconsin affiliated hospitals. During these sessions, residents participated in the human-centered design process to assess the current value of various well-being initiatives and explore further innovative solutions for well-being during residency. These sessions occurred over a period of 1 year and focused on the first 2 stages of human-centered design: empathize and define. We worked with 169 residents, which represents approximately 21% of all the residents localized to the 2 main training sites. Future sessions will include the ideate, prototype, and test stages. We used observation, engagement, and empathy to understand their experiences and motivations to gain a deeper personal understanding of their issues, needs, and challenges. During the design sprints, residents were asked to fill out worksheets that helped guide them through the human-centered design process. Names were excluded from the worksheets, but gender and PGY year were collected. Each resident partnered with another resident in their program, and they were given 2 prompts to choose from to interview each other. The prompts that were given were, tell me about a well-being program you've participated in during residency, and tell me about something you learned that you found helpful and/or something that was not useful. After the interviews, residents had a chance to reflect and create a how might we statement for their colleague as a way to form a potential focus for a solution. At the end of the session, residents were also given the opportunity to confidentially answer the following. What well-being initiatives offered by your program have you found useful? What programs have not been useful to you? And what kind of well-being programs, training, or skills would you like to see your program offer? Resident responses were recorded, and a content analysis was performed for each data set. A group of consensus of themes was created based on the responses. 3 reviewers independently coded the responses into the agreed-upon themes listed here. If discrepancies in coding occurred, these were resolved through a discussion and final consensus. After each response was coded, we quantified the frequency at which these themes were mentioned. By far, the theme that had the most comments related to usefulness was social connection. It also had one of the most commented for suggestions for improvement and referenced during the design sprint interviews, which were captured by the how might we statements. An example of a comment regarding social connection was, quote, "We try to do monthly dinners, which are useful. It is great to spend time together outside of the hospital." An example of a "how might we" statement reflecting social connection was, quote, "How might we help my friend to connect with other residents?" Of note, the most frequently cited as not useful was related to wellness lectures, emails, or curriculum. An example of a comment coded into that theme was, quote, "Lectures on how to improve wellness are less helpful because I already know what to do." Also listed as not useful were attempts at mental health and reflection and therapy. And a comment example was, quote, "It's less useful to talk about burnout and how hard things are." However, within the "how might we" statements, mental health and reflection and therapy, several looked for how to improve this during their interview process, with one example comment asking, quote, "How might we help my friend to feel less stress?" This finding may speak to the quality of the current offerings for mental health and reflection, but that the residents still value this effort. In addition to the global results of our study, we were able to break down these responses by PGY level, gender, and by specific residency program. Specifically related to PGY level, PGY 1s had the most suggestions when it came to scheduled breaks and free time, which may be related to a typically higher workload during the first year of residency. In respect to gender, females also found scheduled breaks and free time to be useful and provided suggestions for improvement. Females also had higher percentages of useful comments related to mentoring and faculty engagement. Males reported the most suggestions in relation to improving physical wellness. By using the human-centered design approach, we were able to identify very specific and targeted themes that residents found to be valuable related to promoting well-being while in residency training. In general, social connection was found to be the most useful and most often suggested for enhancement. We were able to identify PGY level specific items as well as gender differences. In addition, we have created program-specific data since there were differences among the various residency programs regarding needs for improvement related to well-being. This data will be shared with individual residency programs in an effort to help guide future wellness initiatives. And finally, we will utilize the final steps of the human-centered design approach, which include ideate, prototype, and test, to enter into the solution space for individual programs to ensure their well-being efforts are both valuable and robust. Thank you for your time. I hope you enjoyed this presentation.